Ahmed Shawqi for the elegant speaker as usual for preparing the way for the Semaglutide 2.4. Actually, like we said already, that obesity and overweight already the independent risk factor for cardiovascular events and mortality, but and it's still a big deal nowadays, and we have a lot of obese people in our country specifically, and if you define obesity as a problem, it's a very big problem. And almost 70% of this is related to the overweight and obesity are due to cardiovascular disorders, actually. And if we see that we have done something in the past as regard cardiovascular mortality in the past 2 or 3 decades, but actually the cardiovascular related disease due to obesity increased threefolds. So although we have now a primary PCI and a lot of interventions to save life, even in the stroke, but the cardiovascular related disease in obesity increased threefolds in the past 3 decades. And it's a continuum. We have an atherosclerosis, we have a valvular disease, we have a heart failure, we have a thromboembolism, we have an arrhythmia related disease due to the consequences of overweight and obesity. And if we see the International Obesity Collaborative, it said the obesity care is about health, not weight. And weight loss is just one outcome of the obesity care. And we have now the breakthrough medications, specifically the Wegovy, which help now in the transformation of the weight loss and help a lot of people around the world in decreasing the burden of obesity. Now we are talking about the selected trial design, which randomized the semaglutide 2.4 versus placebo, and we have this randomized controlled trial, placebo-controlled, over 40 months mean follow-up, over 17,000 patients, with the primary endpoint related to cardiovascular death, non-fatal MI, non-fatal stroke. We have a significant and marvelous improvement in decreasing risk of MACE in the semaglutide arm was about 20%, which is a very big number in cardiovascular disorders. And actually, the most important part in this trial, the early separation between the MACE and the placebo arm in the semaglutide arm happened very early, irrelevant of the weight reduction. And that's why, like Dr. Ahmed said, we have a lot of mechanistics which help to save lives and improve the mortality, not related to the weight loss arm. If we see here, we have the significant reduction in MACE observed within only 3 months of randomization. And actually 80% of the MACE risk reduction with semaglutide is mitigated by factors other than body weight loss. And like I said, the MACE risk reduction of semaglutide is independent of changes in body weight. If we see here, like I said, the body weight loss, if it is less than 5% or more than 5% in the semaglutide arm, both arms have a very significant decrease in mortality in whatever they have a weight loss or not. Also, it shows a consistent favorable effects across all measured cardiovascular outcomes. Specifically, 19% risk reduction in the risk of all-cause death, and 15% reduction in the risk of cardiovascular death in the semaglutide arm, and 18% reduction in the risk of composite heart failure outcome in the semaglutide arm. Also, it has improved multiple modifiable risk factors, and this might be the mechanism beyond decreasing the mortality. It improved waist circumference by about 7.6 centimeter. It improved blood glucose level because it's an anti-diabetic medication. It improves the blood pressure. It improves the CRP, the inflammation marker. It improves the triglyceride and total cholesterol. All of these modifiable risk factors known to drive cardiovascular outcomes, and this may explain why the semaglutide 2.4 did a lot of important risk reduction in mortality, irrespective of the weight loss indication. Also, semaglutide over significantly lower risk of revised 3-point MACE, which is all-cause death, MI, and stroke, compared to tirzepatide in the still real-world evidence, which happened to, the real world evidence is a very strong evidence. After the trials, you can check the real world studies, and actually semaglutide did a 3-point MACE reduction by 57% versus tirzepatide, which is a marvelous number, a significant reduction. That's why the EC guidelines recommend the use of semaglutide in patients with chronic coronary syndrome without diabetes, with an indication of class 2A, with level of evidence B, and it should be considered without diabetes who have overweight body mass index over 27 kilogram per square meter for obesity to reduce cardiovascular mortality, MI, or stroke. It's a very, very significant indication, especially the BMI over 27. I think most of the people here have a BMI over 27. Semaglutide effect on the heart happen. It's a root cause in heart HFpEF, of course, the obesity. 85% of HFpEF patients present with obesity, and obesity play a critical role in HFpEF pathophysiology. It promotes inflammation, hypertension, insulin resistance, and impair cardiac and arterial skeletal muscle and physical function. And all the studies confirm that intra-abdominal fat is a strong independent predictor of physical function, HFpEF, and also mortality. In the STEP HFpEF trial design, we have about 500 patients which initially take semaglutide versus placebo, and of course after about 52 weeks for dose maintenance after escalation. The primary objective of this study to investigate the effect on the physical function, symptom, and body weight of the semaglutide 2.4 compared with placebo. And it happened that we have a very significant improve in the quality of life as the Kansas quality of life score did, and also we have a significant increase in the mean 6-minute walk distance of the semaglutide 2.4 arm. Also, if we did a pooled analysis of the STEP HFpEF patient which was without diabetes and the STEP HFpEF patient which were diabetics, we have a conclusion of about 1,100 patients, 500 of them without diabetes and 600 of them with diabetes. We have a very, very significant reduction in the time to first heart failure event or cardiovascular death in the semaglutide 2.4 arm, which is a very meaningful result over the HFpEF patients. And we have overall 73% decrease in the time to first heart failure event, which mean a lot to HFpEF patients. As regards the other significant sustained weight loss reduction of the semaglutide 2.4 arm, of course, we have in these patients more participants achieve more than 20% reduction in the STEP 5 trial, with more than 20% weight loss and more than 16 centimeter reduction in the waist circumference. And although the claims of the loss of muscles and loss of lean body mass, we have in the STEP 1 trial data, we have a loss of change of the total muscle, total fat proportion, which is very significant, and the increase in the lean body mass actually in these patients, and the semaglutide 2.4 didn't decrease the muscle mass of these patients in the STEP 1 trial. As regards the MASH, the new data which that semaglutide 2.4, which is the Wegovy, significantly improved the liver fibrosis by 37% and the MASH resolution by 63%. And this did marvelous result was over 72 weeks, which improved the fibrosis with no worsening of steatohepatitis versus placebo, and also improved the MASH resolution in about 63% of patients, which is a very, very significant outcome. As regards the kidney, like Dr. Ahmed said, the FLOW trial and then the SELECT trial confirmed the benefit of the semaglutide 2.4 in the time of the first occurrence in the 5 main components of kidney composite endpoint, and semaglutide decreased the composite endpoint of the kidney by 22%. Actually, like I said, the quality of life, which very significant factor in obesity patients, the knee osteoarthritis and the functional capacity and the physical function, which is happened that in the WOMAC study, WOMAC score of the knee osteoarthritis, semaglutide 2.4 decreased the pain score very significantly, and the physical function score improved with a very improvement in the quality of life for the obese patient as regard the knee osteoarthritis. We have a very simple escalation dose of the Wegovy, starting of course with the dose of the Ozempic and increased to 1.7 and 2.4 all over the duration of 4 weeks interval of each. And if we conclude, the semaglutide 2.4 has extensively studied in multiple trials. We have more than 43,000 people across the all indications studied with semaglutide, and also we have a very cumulative worldwide exposure of more than 33 million patients per year across the indication since 2018, and with a very improved safety profile consistent with all the GLP-1 class. Finally, the safety profile of the semaglutide has been proven in pre-diabetes patient and diabetic patient, in the cardiovascular disease without diabetes, in the adolescents in age of from 12 years and elderly, which is actually a very good indication nowadays. We have a lot of obese children, and also, of course, in the treatment of MASH, in the regard as the obesity and the phenotype of HFpEF and type 2 diabetes and without diabetes, and the knee osteoarthritis patient and renal impairment. Thank you.